Good morning. Dr. Stites is off enjoying his well-deserved vacation right now, and he's left me the keys to the show just one more time. I'm Dr. Sean Coomer. I'm a transplant surgeon and Associate Chief Medical Officer here at the University of Kansas Health System. Dr. Stites will be back next week unless he's enjoying his vacation a little bit longer. Today we're talking about an extremely important topic, breast cancer. It's a diagnosis no woman wants to hear, but there is research into medications that may reduce the risk of breast cancer and alleviate symptoms of menopause, such as hot flashes. With me in the studio are several guests to talk about this research. Dr. Carol Fabian is an oncologist and principal investigator of this study. She is founder of the University of Kansas Cancer Center's Breast Cancer Prevention and Survivorship Research Center. She's also professor emeritus in the KU School of Medicine and has a long and storied career here at the health system. Also with us, Amanda Stiers, a patient of Dr. Fabian's and a participant in this trial, who will talk about her experience. And we're pleased to have Dr. Lauren Nye, a breast oncologist at the University of Kansas Cancer Center, also the medical director of breast cancer prevention. She's going to talk with us about another clinical trial, this one specifically for women who have the BRCA1 or BRCA1 gene mutation. Dr. Fabian, let's start with you. You have received a $4 million 5-year grant from the National Cancer Institute. This is a study of 2 medications in women who are at increased risk for developing breast cancer and are experiencing menopausal symptoms. Tell us about these medications and what the hope is with this study.
Well, these 2 medicines, conjugated estrogen and an anti-estrogen called basidoxifene, are actually commercially available in a drug called Duvet. And Duvet is FDA approved for relief of hot flashes and prevention of osteoporosis. But preclinical studies, that is studies in mice and rats, really pointed to the direction that this drug may actually help prevent breast cancer. Relieve the hot flashes, but the anti-estrogen can work in the breast tissue as well as the uterus to reduce the risk of cancer. So we actually did a pilot study, and I think Amanda, that you're going to introduce next, was actually a participant in that study as well. That showed that this drug, given for just 6 months, actually reduced breast cell growth or proliferation, which is known to be a risk factor for breast cancer, and reduced high breast density in women who are at increased risk for breast cancer. So because of that, we wrote a large grant, and the National Cancer Institute funded us and about 4 other cancer centers across the nation to actually look at this in greater detail. And that's what we're doing now. And we have entered a little over half the participants in about 2 years that we need to show benefit.
That's fantastic.
And we're very excited about it.
I'll bet it is fantastic. We're putting an email on the screen for Breast Cancer Prevention and Survivorship Research Center. It's very key. The big key in there is prevention. That's what we want to get across today in our program. Dr. Fabian, if someone wants more info, they can send to that email, correct?
Correct. Also, our phone number for the Breast Cancer Prevention Center is 913-588-7791.
Okay, we'll make sure we get that up there.
So the email or the phone number, and we'll get somebody to talk to you about the study.
Right, thanks. So Amanda, thank you very much for being here and sharing your experiences with us.
Thank you for having me.
Absolutely. So you were a participant in the study on conjugated estrogen and basidoxifene, also known as Duvet. Can you tell us about your experience?
Yes, well, I met Dr. Fabian back in 2002, and I participated in several studies for the prevention of breast cancer. And this particular study, Duvet, I participated in and found that my symptoms of menopause have been greatly decreased for hot flashes and sleep deprivation. And so I strongly support research in the prevention of breast cancer.
Right. So how did you hear about the study and what led you to enroll in this study?
Dr. Fabian recommended me for the study. I have what's called atypical hyperplasia, and she felt that I would be a good candidate for the Duvet study. And so from there, I did the fine needle aspiration and then did the study.
Great. So when did you learn that you were higher risk for developing breast cancer?
Well, my mom it all started with my mom when I was a teenager, and she had premenopausal breast cancer as well as her sister. I came from Chicago, and the doctors that I worked with there recommended Dr. Fabian and Dr. Fabian's Prevention Center. And so that's how I learned through fine needle aspirations that I was high risk, as well as my mom and my family history.
Okay. Any advice or insight for other women that are just starting to experience menopause?
Well, I strongly support prevention and early detection, and anything you can do to further research in clinical science and medicine, I'm a strong proponent for.
Right. Dr. Fabian, you have some pictures to show us here having to do with your study. Can you tell us what we're looking at here?
Okay. So I think most women are familiar with, or a lot of women perhaps that are watching the show are familiar with having an abnormality detected on a mammogram and going in and get a needle biopsy. Those needles are what we call large bore, so sometimes they're a little scary. This is a different type of tissue sampling where we use a very skinny needle, which is why it's called fine needle aspiration, and we put some local anesthetic in the skin of the breast. We actually sample the outer quadrants and the inner quadrants of the breast tissue. Then we take those cells, we concentrate them in a special way, and look at them under the microscope. Just look at what their appearance. Are they fairly normal? Are they abnormal or more like cancer? We call that atypical. And then we stain them with certain stains to look at different proteins like estrogen receptor, or look at how fast the cells are growing, and that's usually called Ki-67. We've made some remarkable progress over the past years, and these are actually some pictures that are looking at the cells that we obtain. The purplish stain is just the cells themselves. These are fairly normal cells. There's very little proliferation or Ki-67 in these particular cells. This individual had a baseline, and then at 6 months she was on wait list and there was no change in the Ki-67, but she had very little to begin with. This was another individual that was actually randomized to get the drug up front and took it for 6 months. The brown spots are the actual indicators of cell growth, the Ki-67, and you can see that there is a lot fewer brown spots on the second picture, and that's because she had a dramatic reduction in Ki-67. So the cell growth is a definite risk factor for short-term development of breast cancer, and that is one of the primary endpoints in this study. Obviously, since we're looking at tissue, we are doing fine needle aspiration both at baseline and 6 months. That's kind of scary to think about, but these aspirations are very well tolerated, generally speaking. The average pain score is 1 to 2 on a 10-point scale for this procedure.
So sampling is in multiple quadrants, all quadrants of the breast, pulled together.
It's actually, right, it's actually on the outside and the inside. It's just two quadrants of the breast. We pull it together. We not only look at cell growth, but we're also looking at a number of other things, gene expression, for example.
So in those pictures there with the brown dots there, the increased Ki-67, that was an indication of increased growth and rapid growth.
That was an indication of increased growth in a woman who is already at high risk for breast cancer. And the fact that that decreased remarkably at 6 months is a good sign, an indication that not only is she getting relief of her hot flashes, but also, particularly long-term, that this ought to reduce her risk for breast cancer. And that, honestly, that's what's so exciting.
Yeah, very exciting. Prevention of cancer.
Exactly. The drugs that we've had for a long time that have been used for breast cancer treatment, like tamoxifen or aromatase inhibitor, they also will reduce this Ki-67 or proliferation, but unfortunately they increase hot flashes. So most women who are already having them don't want anything to do with those drugs, unless they actually have cancer.
Understood. So Dr. Fabian, what made Amanda a good candidate for this study?
Amanda had actually been in our high-risk program practically since its inception around 1990. And she not only had a strong family history of breast cancer, but we started actually back in the 90s doing these fine needle aspirations to look and see if people who had atypical cells perhaps were at higher short-term risk and needed to really think about prevention medicines. And that's what we found. Women who are already at risk because they had a family history of breast cancer, if they had atypical cells, were at higher short-term risk. So Amanda has stayed in the program. She's been under heightened surveillance. She's participated in a number of prevention studies and has done very well.
So we know you can't give specifics, but you had a pilot study and then you're in the middle of this study. What can you tell us so far?
I can just tell you that the study is going very well. The two main things that we're looking at, breast density, appears to be reducing, just like it did in the pilot study, with beta-doxyphene and conjugated estrogen. Also, it appears that the proliferation is reducing as well.
That's great. There's another breast cancer study we want to talk about. This one with Dr. Lauren Nye. Dr. Nye, this one is for women who have the BRCA1 gene. Tell us what that means and how does a woman find out if she has that gene?
So BRCA mutations are one of the most common mutations that we see in hereditary breast cancer, which only accounts for about 10 to 15% of breast cancer. But 1 in 400 women will have a BRCA1 or 2 mutation, and that puts them at a very high risk of breast cancer, anywhere between a 50 to 70% lifetime risk of breast cancer. And that typically our management for reducing the risk of breast cancer is surgical, because our anti-estrogen medications that we were talking about don't work as well in BRCA1 carriers because they have a higher tendency to get hormone negative breast cancer.
Okay. So if a woman knows that she has the BRCA1 gene, does it mean that she has to wait till she develops breast cancer or taking preventative measures? Can you tell us a little more about that?
In a woman with a BRCA1 mutation, she can undergo high-risk surveillance, like Amanda has been doing, and the goal there is early detection of breast cancer at hopefully a curable stage. But unfortunately, that individual may still have to go through treatment of breast cancer or risk-reducing mastectomy. We don't have a non-surgical option for women with a BRCA1 mutation at this time.
Okay. So this clinical study is seeing if there's another option, a drug called denosumab, and you can correct me if I'm pronouncing that incorrectly, but this is already approved for treating osteoporosis. Can you tell us more about that?
Correct. So we are thrilled that we were invited to participate in this international study. That is the BRCA-P study that is looking at denosumab, which is a medication that's been used for a long time to treat osteoporosis, and it's now being investigated to see if it can stop the development of breast cancer, specifically in women with BRCA1 mutations, which is an unmet need in prevention.
Okay. So who is the candidate for this study?
Women who are between the ages of 25 and 55 and have a BRCA1 mutation, and they cannot have a history of breast or ovarian cancer, they cannot be pregnant or breastfeeding, and they have to have breast tissue.
If you have any questions for Amanda, Dr. Fabian, Dr. Nye, or myself being the least qualified to talk about these things, please send them using the links on your screen, YouTube, Facebook, the X platform, or email the Medical News Network. Alexis Del Cid is monitoring those questions, and we'll check in with her in just a moment. Before we check the COVID count, as you know, I usually put the transplant numbers up. Let's look at the transplant waiting list. Across the country, more than 103,000 people are waiting for an organ. But let's look at the patients waiting here in the University of Kansas Health System. As of Monday, we have 475 transplant candidates waiting for an organ. That includes 327 people waiting on a kidney, 125 people waiting on a liver, and 14 people waiting on a heart. I want to thank everyone who is willing to donate their organs and encourage you to check out registerme.org or donatelife.com to sign up to be a donor or verify that you're already signed up. Again, that's registerme.org or donatelife.com, and also the DMV can help with this. Now let's turn and with Dr. Hawkinson and talk about the COVID count. He is the Medical Director of Infection Prevention and Control here at the University of Kansas Health System.
Hi. Yeah, good. Well, I am an organ donor. I did sign up with my driver's license, but don't get any funny ideas. So, otherwise, the COVID count is good. You know, I know that you are happy. We are getting down to that low number, close to zero. We have 3 active patients in the hospital, so single digits. So it is going the right direction. Overall, respiratory viruses are really decreased in circulation right now. Again, we're kind of out of that respiratory viral season. We do expect SARS-CoV-2 to have a little bit higher circulation than, say, the other common cough and cold viruses in influenza now moving into the next few months. But hopefully we can keep those people out of the hospital and keep them well.
So I've been giving you a hard time about this for a while. We've been talking about COVID. I want to get past it. Everybody wants to get past it. But I did hear correctly, as of next week, the COVID count is ending.
Yeah, absolutely. Again, you know, a lot of issues with COVID are not anymore required to be reported to CMS. We know that it is still a significant disease. It still affects a significant group of populations that we have in our community. Again, for the most part, COVID does not affect most people's lives, and we know that there are other resources we could be using to collecting that data and reporting to other more prioritized categories and things right now. So yes, unfortunately, those numbers will cease to be presented, at least on a regular basis.
So we've got to get more things for you to talk about, Doc Hawk. So this is one here. You've seen a new study that asks if adult vaccination programs are financially worth it. Sounds like maybe they are?
Yeah, absolutely. And I know that, you know, working with your group, you guys are one of the biggest proponents of vaccination. We know and have heard and do understand that when you have healthy populations, everybody in the community does much better. This was a study published by the Office of Health Economics, which is an independent company. It's an independent group, been around for 60 years. And what this essentially did was look at 10 different countries and looked at 4 immunization programs. So it didn't include the COVID vaccination, but other common vaccinations that we should be getting as adults. Again, this was an adult study. So it looked at influenza, herpes zoster, or what is shingles. It looked at the pneumococcal vaccine, which we refer to as the pneumonia vaccine. And then it looked at RSV. And what they found throughout those 10 countries was that when you had people who were in those immunization programs and getting immunized, it saved money and it saved mortality and morbidity. We know that there has to be very many reasons why we continue to support and promote vaccination. And one of these things is economics, and it is important. And what they found was that when you invested in immunization programs in your country or in your community or in your institution, there was a 19-fold return on that investment. So up to $4,000 per person that you were saving or helping with the economy because these people were still healthy, because they weren't affected by the disease as greatly as if they hadn't been vaccinated or immunized against these diseases. So I think we need to attack vaccine misinformation from many angles, certainly transparency, safety, and efficacy, but also economics is one of those as well. And this is one more strong data point proving and showing that vaccination programs do help you as an individual, but also society.
Thanks, Dr. Hawkinson. I really appreciate your help us educate everyone. We know many of you have questions. Let's head to Studio B with Alexis Del Cid.
Dr. Coomer doing a great job this morning.
Can't hear.
Oh,
Love
Alexis.
having you. Gretchen has a request. Gretchen wants to know if you can talk about the breast cancer risk assessment tool from the National Cancer Institute, because she wants to know, is it just to help doctors or can anyone use it?
Dr. Fabian or Dr. Nye?
The breast cancer risk assessment tool from the National Cancer Institute is a very simple tool that anyone can use simply by going online. It probably is a little too simple, but that at least gets you started to see if you possibly need to get to more sophisticated assessment of your risk like the Breast Cancer Prevention Center. It is very applicable to women who have a maternal family history of breast cancer. It's probably not applicable to women whose major risk factor is perhaps a paternal family history, or women with some types of biopsies. So again, anybody can use it. Doctors, patients, anyone. It's simple. It takes 30 seconds to get through it.
Dr. Nye, anything to add?
No, in the Breast Cancer Prevention Center, we do use that risk assessment tool as well as more sophisticated tools, including genetic risk assessment as well, to fine-tune and personalize a woman's risk of breast cancer. But it's a great starting point and a great point to get interested in. There's been a lot in the media about knowing your breast cancer risk after a celebrity recently talked about knowing her risk of breast cancer leading to her diagnosis. So we would encourage anyone with a family history, abnormal breast biopsy, to find out their risk of breast cancer as well.
Okay, there you go. So anyone watching could do that this morning. Melissa wants to know, how do I know if I should get genetic testing for breast cancer?
Dr. Nye?
So anyone with a family history of breast cancer, especially in multiple relatives or in a relative who was diagnosed under the age of 50, would warrant genetic testing. There's other cancer diagnoses, though, that also would be indicative of a genetic risk, including ovarian cancer, pancreatic cancer, prostate cancer. And so really getting to know your family history and talking to a genetic counselor. We also do genetic risk assessment and testing in the Breast Cancer Prevention Clinic. And like I mentioned earlier, women with an Ashkenazi Jewish heritage are also at an increased risk of being identified as having a BRCA1 or 2 mutation.
We have an interesting question from Melinda. Melinda just wrote in asking, can I ask for a fine needle biopsy? Is that standard?
No. There are, I think, I'm having a little trouble hearing you, and I'm not sure if this is Sarah that wants to know about the risk factors for breast cancer.
I can repeat the question.
Somebody wants to know about, is a fine needle aspirate standard for risk assessment?
Correct. Yes, you got it.
No, but it is one of the tools that we employ for short-term risk assessment, as well as a tool that we can use that is much more comfortable for the woman to tell if she is at baseline high risk, and even more importantly, if she is responding to the medications that we're using in the clinical trials.
Okay. Have a question from Abby. Abby wants to know, does breastfeeding reduce cancer risk? If so, do we know why?
I'm going to repeat the question. It is, does breastfeeding reduce cancer risk and why? And so we do think there is a benefit to breastfeeding in reducing cancer risk. And there's a benefit to childbirth, basically when your milk comes in your breast tissue that allows your breast cells to mature, and they undergo less proliferation every month, and therefore they're less likely to develop a breast cancer.
And then I just want to get some clarification. Sarah asked, what are the risk factors for breast cancer? And do you have any specific recommendations of what she can do to prevent it?
That's a big question. There are many, many, many risk factors for breast cancer, as you can imagine. The strong risk factors are some of the genetic things that Dr. Nye has been talking about, BRCA1, BRCA2, and there's other genes as well. But fortunately, very few women have those. Fairly common risk factors are having very high density on a mammogram, which should be reported on the mammogram that every woman should get, regardless of risk, after age 40 yearly. Family history, breast density are some of the strongest risk factors. Another very strong risk factor is having a biopsy which is interpreted as precancerous. So having atypical hyperplasia, having non-invasive or in situ cancer, another strong risk factor. These are all not real common risk factors. Some of the most common ones, they don't impact a lot of risk, but it increases your risk, are being obese after the age at menopause, after age 50. That increases your risk by about a relative factor of 20 to 30%. Drinking more than 7 drinks per week, that's something everybody can do to reduce that. We're learning that exercise is very important to reducing risk, and being a couch potato or sitting there on your computer 10 hours a day, which increasingly we all do, is also a risk factor. People ask us all the time, well, how much exercise do I really need to do? A minimum probably of about 3 hours a week, and fast walking will do it. But if you can get up to 5 hours a week of aerobic exercise, that may reduce people's risk by a relative factor of 20 to 30%. And it's good for everything. It's good for your brain, it's good for your heart, it's good for your lungs. So minimizing alcohol, getting that exercise, keeping your weight at a normal level, those are all important things that everybody can do. Another thing may be making sure that you're getting an adequate amount of vitamin D. Lauren, anything you want to add?
Nope. I think if you can focus on diet, exercise, and limiting alcohol, you'll be off to a really good start.
Probably for good news and good advice for everyone. This has been a great discussion. I'm extremely grateful to our guests for being here. I'd like to get some final thoughts from everyone. Amanda?
I would just like to strongly encourage all women to make sure they know what their risk factors are and attend the Breast Cancer Prevention Center if you do have risk factors.
Dr. Fabian?
I would very much like to thank people like Amanda for participating in research all these years. I believe that Amanda has undergone over the years about 18 of these fine needle aspirations. So she is an incredible person. She strongly believes in research, and we've made some tremendous advances both in breast cancer prevention and breast cancer treatment because of people like Amanda.
That's great. Dr. Nye?
And I would just say, find out your risk of breast cancer and know that clinical trials are options in the prevention setting as well. We don't only look at them in the treatment of cancer, but preventing cancer is really important, and participating in a clinical trial can get us closer.
Thank you all. My final thoughts would be, I don't think there's anybody that doesn't have a personal or professional story being touched by cancer, no matter what that is. Mine happens to be a grandmother I never met that passed away from metastatic breast cancer on Christmas Eve. And that, my dad lost his mother in his 20s. And that is what we're trying to talk about today, is prevention. So please be screened no matter what the cancer is. Thanks again to all of our guests and to our audience. I've enjoyed filling in for Dr. Stites for these last 2 weeks, and he'll be back next week for another edition of Open Mics with Dr. Stites. Have a great day.
Born months early at only 3 pounds, her newborn also had a heart condition. I'm Alexis Del Cid. On the next All Things Heart, how our medical team treats the tiniest of hearts.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.